the attendees are really following us. How many of you have had the opportunity to see cardiac MRI in their own hospital? Can you answer, please? The attendees? So they can hear us, or? As I said, they did not. That's a good answer. Okay. And Abdulaziz. Turkey, yes, we have the opportunity. Not available for them. Kazan, they often use it in other parts. That's good. Several times. So for those who never heard or seen cardiac, just touch base very quickly about what is this procedure represents and what is the images that you expect to see by cardiac. And then I will go deep dive into the utilization, the clinical use in our cardiology practice. First of all, I would like to say that cardiac MRI is now designed as a gold standard for right ventricular assessment, and that has been agreed by evidence regarding the limitation for other modalities to assess exactly the right ventricular dysfunction that right ventricles has. There's also a part in congenital heart disease and under congenital heart disease and tricuspid valve disease also. So the only gold standard for that among the other modalities. In addition to that, cardiac MRI has superior acoustic window. It means that if the patient is obese, whether he's having difficult echoing, that is not a limitation of cardiac MRI. We don't have any limitation to see images, and images are really clear for all cardiac structures. And the most important part is the free of ionizing radiation. So we're not afraid to get the patient inside the scanner for 1 or 2 hours. There is no radiation towards all magnetic field that has been generated through this technique. Then actually what are we doing? It's just I'm going to talk basis about. Yes.
The voice is not very clear. Mic maybe.
My mic is not. Okay. Is that clearer now for you?
It's better. Now it's better.
Okay.
When the mic is closed, I think it's better.
Yeah, it was. Okay. So you didn't hear anything from what I said, or you were able to? Hello?
We can hear you, but it's not very clear.
Okay, so I'm going to just go back to the first slide, and I was saying that cardiac MRI is the gold standard as a modality for right ventricular assessment. And in regard to comparison to other cardiac modalities, cardiac MRI has a superior acoustic window. It means the body habitus, whether the patient is really obese or not obese. This is not going to be you have very clear imaging for the cardiac MRI. And the third thing is it's free of ionizing radiation. So keeping a patient in scanner for 1 hour or 1 hour and a half is not going to subject him to a high radiation dose, because the technique itself is counting on the strength of magnetic field rather than sending X-rays through the patient body. This is I'm going to touch base on the basics planning when you are doing cardiac MRI. We have long axis plan. We have also the RVOT and left ventricular RV and 3-chamber, 2 chambers. We can assess very clearly the adrenal motion irregularity. We have short axis in the stack. Rather than having it in echo, we have basal and mid and apical view. The MRI has more than 12 short axis in the stack, and that is one of the superiorities to have calculated the left and right ejection fraction without having any data or estimation like echocardiogram. Again, I'm talking about the right ventricular ejection fraction. It's a very robust technique, and it's the only technique that can consider to be the gold standard for the right ventricles. And also we have the opportunity to assess right ventricular free wall assessment that has been needed also for patients with arrhythmogenic cardiomyopathy. So keep in hand this is what you are expecting from cardiac MRI, and this is just to make you familiar of what the images that I'm going to get you through it. So if you look at my slide here, this is the short axis view, and this is left side, left ventricles, and this is the right ventricle where my pointer is. And actually, during acquisition, the cardiac MRI, we had the protocol designed just in Fury. This is the anteroceptor wall, lymphoceptor wall, and when we do that, actually, we are going to acquire the most important images here is the right ventricle, the four-chamber view, which is the left and right ventricle, right atria, and left ventricle. So this is how we actually design the protocol. Again, we can do another planning this way, and then we can get the two-chamber view as you see it here. This is the left ventricle, this is the left atria. So again, as I was talking about short axis view, so we take multi-slice semi-stacks through the right or left ventricle. It has to be perpendicular, and you will get the semi-stacks through all the left ventricle. So starting from the base of the heart, this is a mitral valve, and then you go basal mid up to the apex of the myocardium. And from that views, we can calculate precisely the left and right ejection fraction with our software. So that's what's expected basically. And as I said, right ventricle, then you are going to plan here in the right ventricular chamber, you cut through it, and then you have very nice two views of the right ventricle and right atria. You can see beautifully the contractility all over the whole wall. So you don't have limitation actually to see the precise pathology if you are asking for that. The other thing that you expect to have with cardiac MRI is to give a contrast, which is a gadolinium-based contrast. And yeah, I'm sure about that you heard about this gadolinium contrast. But what is the difference and why we are taking that contrast into interest? Because gadolinium, it's a large and high density element, and this density, it just gets into the extracellular space. And after we give the intervention, the intravenous injection, but this the gadolinium itself, it's unable to cross in the living cell membrane in normal myocytes in the myocardium. So, if the myocyte has been subjected to a damage like acute myocardial infarction, or there is an increase of extracellular space, like what happened in acute in edema, acute interstitial edema, or chronic fibrosis of myocardial infarction. So we have a large extracellular space. At that time, gadolinium find itself a place to sit in. So whenever you see a gadolinium inside the myocardium, we know that this is going to be a dead space that the gadolinium is based on, because normally a normal myocyte will never absorb gadolinium. And that is the crucial part whenever you go to a further evaluation. If I've been asked to do a cardiac MRI without gadolinium base, you know that you're missing most of the data that you're going to gather from cardiac MRI. So my topic now is going to be specific in ischemic cardiomyopathy. So far. Hello? Hello? Is my voice really clear to you?
Yes, Doctor. It's clear.
Okay. So now I'm going to ask you to interact and actually to answer questions, but just make sure that you hear me. So ischemic cardiomyopathy is most common that you're facing every day in practice. This kind of pathology, and I will speak about cardiac MRI.
Sorry, Doctor, some of the participants are not hearing you clearly.
Okay. You get that, sir?
Yes.
So is it really interrupting? Do you face interruption? Hello?
Probably the internet.
Is it stable internet for you?
For me, I can hear you clearly, but maybe not for everyone.
So right now, is it better? You can hear my voice, or you want me to just something?
إيه قطع شوية دكتورة فعلا.
ما زال يقطع؟
إيه شوية. Maybe at the end of the sentence sound كده interrupted.
Interrupted, okay. Just maybe if I turn off my video, you will have better signal. Is that okay?
Yes, sure.
So how is it right now? To adjust the, yeah, now is better?
Yes, it is better.
Okay. Okay, we'll go back. So in ischemic cardiomyopathy, we are, as I said, we are counting on so many parameters to decide in ischemic cardiomyopathy. The left ventricular systolic function is really important. Most of the patients subjected to coronary artery disease, they have left dysfunction. So you have a robust technique to assess the ejection fraction through cardiac MRI. The second thing is viability testing. I believe that you have heard about this viability testing for a patient for MRI to have a viability test. And there is a reason to choose that because of what I'm going to explain to you. And among the multiple invasive modalities, non-invasive modality, the Butinous chest echo or the SPECT scan, MRI is more robust technique. All of those. So we use it in viability testing. And actually, that's what I want you to focus on, is the strength of the cardiac MRI to be a predictor for the future and an adverse cardiac event. So this is generally the guidelines or the rules that we use cardiac MRI in. And actually what we are seeing, patient with ischemic cardiomyopathy, is a phenomenon called hibernation stunning. And have you heard about this terminology, hibernation and stunning? Did you? Like, this is a stunning myocardium, this is hibernating myocardium. Is this a familiar term to you? Yes, very good. Okay, the hibernation in terms of ischemic cardiomyopathy is where the myocardium is hypocontractile. There is no contractility. Definition says it in the echo, you see hypokinesia or akinesia counter. And most of the time we would say that, well, this would be is dead. And the other terminology is the stunning myocardium. Stunning myocardium is when there is actually a transient or ischemic insult, actual ischemic insult to the myocardial cell. And this is followed by reperfusion therapy, and then the myocardium is really not contracting yet. So in terms of definition, hibernation doesn't sound that the patient has an ischemic insult beforehand, but the stunning is happening after the ischemic insult. The difference is that both of them is not going to say that this is a viable myocardium. So the role of MRI is to identify those two phenomena. If this tissue really has been insulted, if this is not only a hypocontractility with akinesia related to a real myocardial death, rather than that this is an hibernating myocardium, it is because a chronic, and there is a metablically active and chronic hypoperfusion. So there is a chronic hypoperfusion. The response of the myocardial cell is becoming hypoperfusion. The stunning myocardium is when you have an insult, an actual insult, and you resume the reperfusion, and yet the myocardium is insulted. Then those are two different, and that is where the viability is. The viability says, oh my God, this is a dead myocardium, and this is not dead myocardium. It is only hibernating, it is only akinetic, but it's still viable. And that is the role of the gadolinium contrast that I'm going to explain to you. So is that clear for you right now? The voice is fine? Yes? Okay. Then the next thing is also a question that we asked in cardiac for successful revascularization. And actually, we are going to measure for our revascularization where the patient actually will be finding it as a successful when the patient has an improvement of global LV ejection fraction or there is an improvement in the regional bone thickening. And despite that, this definition is really not the accurate one, but this is the only marker that we are using to just say that whether this patient has a successful revascularization, he has a good functional recovery after revascularizing by carriage or by PCI. And despite the fact that we really don't know when the myocardium is going to regain the viability. Is it 2 months after the revascularization? Is it 3 months after revascularization? But right now, we do have only this kind of marker, which is the functional recovery after revascularization. So what we are doing actually by cardiac MRI is assessing, as I said, the viability and giving the patient a guidance to use this technique. And in 2013, in the ACC American College of Heart Failure guidelines, it supported viability testing for planning revascularization. So we don't know this patient is going to benefit from PCI. He has a severe LV dysfunction. Shall we do that or shall we do that? It is a class 2A recommendation with a level of evidence B. So it is indicated and it is useful to be used if you learn how the answer to give. Also, with patient presented with a STEMI, the European Society of Cardiology in 2017, stated that ischemic viability can be an available modality and considered prior discharge of the patient after STEMI, and it is a class 2 recommendation. I know it's not really a strong evidence, it's a level of evidence of C, but it's class 2. So you can use that for patient with STEMI, you can use it for patient with heart failure, with coronary artery disease, and you are not sure about whether this is beneficial for patient with revascularization. But you have to be very careful about what is the viability is going to give you. As I said, the reversibility of myocardial function is going to be tested by cardiac, right? And there are two criteria, or one of the most important criteria that has been documented and has been validated to say whether this is reversible or this is non-reversible, which is the transmural extent of myocardial infarction. It means that whether we see that there is the whole myocardium is scarred, or maybe 50% of the myocardium is scarred, or maybe 25% of the myocardium is scarred. So the presence of a transmural scar is the indicator so far has been defined by the cardiac MRI. And that has been shown actually and has been tested in a small study, 41 patients. They are having a stable coronary artery disease. This patient has been scheduled to coronary revascularization. And actually they underwent the cadaveric cancer. And before the revascularization, before they entered revascularization. And they assume, as we are assuming, that the transmularity is an indicator of a poor recovery or non-successful revascularization. And actually what they have seen is that it was, regardless of the dysfunction, regardless of everything, the only sensitive test to say that this is unsuccessful and fruitful revascularization is the transmularity. So this is the result of the study I'm talking to you about. So note that I'm not talking about akinesia or hypokinesia. That wasn't indicated. So it's all dysfunctional cells, regardless, akinetic, dyskinetic, severe hypokinesia, dyskinesia, maybe segments with akinesia. They took all kind of dysfunctional anatomy you can see. And then they compared the improved in contractility by percentage comparison to transmural extent of the hyperenhancement of the gadolinium. So the patient here, you can notice that the patient without any scar, there is no gadolinium enhancement, 0%, they have a very high percentage of recovery, 80% they recover from revascularization. Here, if you go 1 to 25% of transmurality, you can see they are around 60%, so 50% of 60%, they are going to have a beneficial from revascularization. And the numbers goes down whenever you have 20 to almost 50% is 40%. And if you have almost 75% scarring in the myocardium, if you have 100% scarring in the myocardium, you are, by evidence, you are not going to have infection. and that's including for all segments, hypokinetic, akinetic, and this is actually a very, very clear relationship. No gadolinium, a very high functional recovery, 100% the patient will recover, even if the segment is akinetic. So that is a robust data that you can count when you are going to assess the patient whether he has a fruitful revascularization or not. Now I'm going to talk about terminology that most of us describe an echocardiogram, which is a thinned out myocardium. Oh, this myocardium is akinetic, it is thinned out. We assume, and all my physicians assume, that this is one of the indications that this myocardium is going to be useful or beneficial for revascularization. But I would love you to pay attention to that. As I said previously, there is a stunning myocardium, hyperkinetic. Both are, they are akinetic. What about thinned out? There is no contractility at all. There is almost half of the wall is thin. So you cannot argue with that. But actually, I will give you data, which is very, very robust. 1,055 patients with coronary artery disease. They wanted to carry MRI biological system. And they compared patients where they have regional wall thinning out. It means that the wall is more or less than 4 millimeters, and they saw the thinned out myocardium, and they compare it with the percentage of the scar burden on that myocardium, and whether this scar burden is less than 50% of that thinned out myocardium or more than that myocardium, and the results is really not what we expected it to be. That regardless of the thinned out myocardium, if we have more than 50% transmural scar, then this is not going to be recovered. And if you have a thinned out myocardium and you have less than 25%, less than 50% scarring, this myocardium is going to recover. So here is the example here. You have a patient before revascularization. This is the myocardium here, and they measured it around 8 millimeters. This is before giving contrast, before giving gadolinium. And after giving the gadolinium, as you see here, this is a wide signal intensity. I will explain to you later how you can see it. But this is the wide signal intensity. This is the gadolinium enhancement. This is the rest of the myocardium, that black signal here, and they measure it. It's almost 50%. So this was about 8 millimeters with the measurement that the scarring is occupying almost 5 millimeters. So we said that this is 50% scarring. The myocardium is thick here, it's not thinned out, just to remind you. And the other patient here, you can see, this patient has a thinned out myocardium, not very thick, almost before the revascularization, and it was around 5 or 4 millimeters of thickness. After gadolinium, you can see that the wide signal is here. It's not really measuring more than 15. When they measured, it was almost 3 millimeters. So it's less than 50% transmural scar. So those patients, this is not thinned out. This is thinned out myocardium. This is 50% scarring. This is scarring. And after revascularization, they followed up the patient, and the patient with preserved thickness, 50% scar, they have basically no functional recovery at all. And the patient with thinned out myocardium and less scarring, they have, after the revascularization, you can see the contractility and regionality, it's recovering almost perfectly. So this study is very robust and very sensitive. And the point is that thinned out myocardium is not a representation of viability unless you assist with gadolinium and make sure that this akinesia is related to a scar, or this is only a standard of hibernating myocardium during ischemic insult. Is that clear for you? Do you have any questions so far? Do you have any questions? Hello? Can you hear me well? Do you have any questions so far?
No question, Doctor.
No questions. Okay, so now I describe to you the fact that how we use viability and just the data that we are going to get from MRI. I'm going to talk about the markers in cardiac MRI that describe the prognostic value for the patient. The prognostic value means the mortality, major adverse cardiac event, those kind of things. So one of the prognostic value that we always see describing cardiac events is microvascular obstruction. And actually, that's a phenomenon that we see in cardiac MRI, and it is characterized by damage and dysfunction of the microvascular structure in the myocardium. There is no reflow phenomena, and we see it after patients go into STEMI and they have a reperfusion scan. Actually, the data and literature interested to follow up what happened to those patients. They have microvascular obstruction. Unfortunately, the prognostic significance shows that those patients has a very high prediction of adverse left ventricular remodeling, major adverse cardiac events happening to those patients with microvascular obstruction. The other markers that we are expecting to have is the prediction actually of ventricular tachycardia, ventricular rhythm. And I'm sure about that. You've heard about patients that after cardiac event with ventricular dysfunction, they are maybe indicated to have an ICD to prevent sudden cardiac. Well, actually, the thing that has to be mentioned here that actually MRI is able to predict those kind of patients that is going to have a ventricular tachyarrhythmia using the late gadolinium enhancement. And that has been studied actually, despite it's a small patient number, 137 patients. They have been evaluated whether they have to have an ICD replacement according to the guidelines with left ventricular ejection fraction. And some of the patients, they have more than 30% ejection fraction, so they are not going to have ICD implant. And some of them, they have less than 30% ejection fraction. That those patients, they're subjected to have the ICD implanted as per guidelines. And actually, the left ventricular ejection fraction was not the predictors of sudden cardiac death, neither a VT or appropriate shock to the patient. The only predictor that has been found is the amount of cardiac scarring found in the bicardiac MRI. And this amount, believe it or not, is not really significant. So it's more than 5% of the left ventricular mass. Scarring is enough to cause a patient severe or interesting or adverse cardiac events. And I'm going to show you the results of this data. So patient would have more than 30% ejection fractions. We would consider him not for ICD, but his scarring is more than 5%. So this is the event rate along the month. The event rate is increasing for those patients. So when they take the patient with less scar, less than 5% with more than ejection fraction, look at the events rate to this patient. It's very, very minimal. So it's less than 10%, but here is 20, 30%. So the ejection fraction by itself was not enough marker to predict this patient has a death or ICD shock. So this is a very nice also presentation of the same study. They took patient A, and he has ejection fraction of 33%, and the scarring was about 22%. And this is the amount of the scar, the wild, signal, and passive. His ejection fraction is 33%. He has an ICD, and by this definition, I told you more than 5%, he is going to have a serious event, and that was documented truly through the ICD. He has an VTAC, the ICD gave up shock. We have another patient here that has ejection fraction 28%, which is very low, but he didn't have any scar over that. So this patient, when he has been followed up, doesn't have any major adverse cardiac event. The other patients here that he has ejection fraction of 46%, but his scarring is 17%. So this is his ejection fraction. This is the amount of the scar that we have. This patient, when he has followed up after 18 months, he had a sudden cardiac. did not have an ICD because he wasn't have an indication, but this patient actually had. The other patient here is a 49% ejection fraction with a scarring of 13%, and this is the amount of the scar that they found. And actually, this patient has an ICD shock property for vertical tachycardia. So it was an interesting study, but actually, because of the amount of the data, the study was not really strong evidence to change the guidelines and have the scarring evaluation by cardiac MRI as one of the indicators to have an ICD implantation. Here, I will stop, and actually, I will ask you to participate in one case example. I want you to give me what is your finding data that you can see from this case example. So be ready, please. If you want to open your mics, you want to participate in the shout out, feel free. This is a patient referred for cardiac MRI after coronary disease, and I'm not going to say what was the event itself. And I'm going to display the views. And for all of you here are not familiar with MRI, this is right ventricle, this is right atrial, this is left ventricle, this is left atrial. So this is the display and singing for the patients, and I would love any of you to participate and describe to me what do you see on this image. Fortune review. Any hands for that? Can somebody open the mic and describe what is the writing in this view? Do you want me to pick up names randomly, or you would like to share?
Or chamber?
Yes, this is a four-chamber view, exactly. And what do you see in this four-chamber view? Describe the event. Yes, yes.
Typical akinesia.
Okay. What is your name? Apical akinesia. Who said apical akinesia? Okay, what else?
It looks like there is apical thrombus also.
Yes, interesting. Yes. What else?
And akinetic apex as said.
Exactly. And what about the rest of my body? How is it? Is it contracting? Is it
The contractility at the basal and mid segments looks good,
Mhm.
but the apical and distal anterior there is akinesia and thinning out.
Thinning out of the apex or the whole septum?
Apex and distal septum.
This is septum. Okay. So from four-chamber view, you have a suspicion of LV thrombus, and we would say that this is akinetic apex. So mid or distal apex, that is akinetic.
Distal apex.
Distal apex is akinetic. So from four-chamber view, this is what we gathered, and I'll move next to it. Here, this is a two-chamber view. Can you describe what you see? This is the same thing. Anyone wants to describe what is the abnormality of this view? Hello?
Two chamber showing also reduced ejection fraction. Anterior from mid to distal anterior wall akinesia.
Akinesia, excellent. You compared the thickness to this previous four-chamber view. What do you think about this thickness of my anterior?
Thin.
It is
It's
thick.
thin,
Yes. Yeah, we measured that. It was 4 millimeters. So you have part of the myocardium extending out is 4 millimeters, and you have akinesia. you see something else? Something that is like bothering you?
Fusion or pericardial fusion.
No, there isn't. In the left ventricle version, what do you think about this smoke? This kind of
Smoke, yeah.
smoke. So
Yeah.
that goes with what?
Thrombus.
Okay, so you have seen some smoke in the left ventricle. You would think that this is a sluggish flow, right
Yeah.
or wrong? So that is kind of the pathology that you might have of things, right? So I'll move to the other view. So the third chamber view, the same patient. This is the anteroseptal wall, as we described it. You can see the anteroseptum is akinetic, but the thickness is still there. I do agree, right? There's also something else we can see. Anybody can comment?
Here there's a apical thrombus in the apical area.
Yes,
Peripheral
it's
apex.
very more beautifully seen here. It's locating mass in the apex. That's the point is that you might see it in one view. You can see the other view better than the rest. So don't just conclude the left ventricle thrombus from one team and the system. Okay, so this is a lot to show you exactly the interesting finding, which is the smoke that we the two chamber view. Actually, if you zoom it in, you can see that this is the smoke, and then down here you can see some structure going back and forth, and that was really a thrombus that we suspected to see. And this is part of the study that we have done. That is before giving patient contrast. Keep them in mind. And before giving the contrast, this is how you see the myocardium. It's dark. This is the blood flow here. So that's how it appears. Then we proceeded with the next step of the exam, which is the gadolinium contrast. Gadolinium contrast, we have it two phases: early and late gadolinium. The early gadolinium is designed to see the kind of thrombus that we are suspecting. And the late gadolinium is where you can see the myocardium scarring. So we'll move to the next. This is the early gadolinium, and you can see beautifully that part of the myocardium that we suspected of thrombus is dark here, signal giving you, and this is an indication of a clot in the early gadolinium. I go to the the four chamber. Can you see something? Can you see the LV clot? Or you can't. There is no mass in the left myocardium in the apex here. So, but there is something wrong with this patient. Anybody can suggest something with this one? It's something that I have described.
The dilated RV.
The dilated RV, no, actually by measurement, but visually you could say this is dilated RV, but actually when we did the calculation, the RV was fine. The abnormality is in the limit. And actually it's not an easy question, but just to do it. Actually, what you see here, actually the myocardial signal is all green around the area. It is. And then you can see some very dark black signal here, darker than the other area of the myocardium. And this dark signal is what I have described to you as a microvascular obstruction. So I saw a microvascular obstruction from the mid-ventricular wall to the distal ventricular wall to the apex. What does that mean to the patient himself? That he's having, he has an instance, has probably an obstruction, he has a reflow. But actually, after reflow, the revascularization, he has a still part of the myocardium has no reflow. So, what is your expectation for this patient? So he is going to have a reverse modeling. Is he having a major reverse cardiac arrest, or what is your expectation? Is he having a problem in the future or not? Yes or no? Anyone can answer? Yes. So in mitral liposuction is not uh, is not a good indicator. It's a major indicator that this patient prognosis is going to be safe. Then this is another for the same patient. This is the early gadolinium. This is the late gadolinium. The early gadolinium here, as you see, that we see that this is a contrast, bright contrast. This is the dark spot here that we saw earlier in the semi of the semi images suspected there is a thrombus. It is confirmed in the Now I'm going to go to the late gadolinium asthma. Usually, normal myocardium shows that dark black signal, and anything white, bright like this, is where the contrast is lying. It means that this line is a dimmed area. So I want your comment about what is your estimation of this sky? Is it transmural? Is it near transmural? Is it only just limited to the sublingual cornea? Anyone can answer? Transmural. Anyone else could say this is near transfusion, this is 50% only? Is it 50%? Anybody would say it's 50%? Well, actually, how would you answer this question? Actually, you would measure the breast, the dark area you were breasting, measure the white area, compare how many millimeters. I would say this is, yes, it's a subendocardia, but is it just limited to 25% of the myocardium, or is it taking from the subendocardium to the whole scarring? The way you are going to answer it is actually you have to see what is rest of black myocardium is there, and you measure it. Maybe this is 2 millimeters. Measure the scarring area. It is more than 75%, so it is near transmural to endpoint, and that is involving the anterior wall from basal anterior wall to all the apex anterior wall. It becomes signal. It is done with the LED to produce it. When looking at this view, we would say that this is subjected to an anterior with a left ventricular. I'm going to see the next picture, and I want you to describe it for me. This is the port chamber that we have seen earlier. This is the mitral obstruction here. And then after we do the gadolinium enhancement, this is what is the area. This is scar area. As you see. So that actually confirms that this is the scarring. Here is the scarring is not really transmural. It is near transmural. It's 50% down. So you know that the myocardium is divided into anterior wall, into superior wall. So when you do the viability, you have to give the percentage for each one segment. And you don't stop on one myocardium. This is a short axis with a small, very nice presentation to make sure that you're really not overestimating or underestimating the gadolinium. There is still some myocardial left here or not. That's very essential for the patient to that. So from this patient, we gathered from cardiac MRI the data that this patient is having a serious problem. So if this patient has been referred to you, and you have been asked whether this patient needs a pre-vascularization or not, what is your recommendation? What would you say to the physician after seeing this data? Would you recommend for re-vascularization or not? Any hands? Who would say he needs revascularization? So we have hands for revascularization. Who would say no? I will not refer to this patient. Who would say no, don't refer this patient for revascularization? This is a very, very important question. You have to answer very quickly. Who is for yes? Just send me in your chat box. Yes, I want to send this patient for revascularization. I have Hassan if I want to see. Who is else with Hassan? He thinks that this patient needs revascularization. No? Anybody has any comment? I need answer for no. Everybody agreed that this patient has to go for revascularization. Is that yes or no? Can you answer, please? Okay, so most of you think that this patient will benefit from this. So most of the audience think that this patient sustained to myocardial infarction, given what I have seen in the MRI, you will recommend this patient to go for revascularization. Now, I would love to go back to here and assess your evaluation. We have said previously that the percentage of successful recovery. Hello? We have some. Hello? If you're going to participate, you can talk. You are not, you can mute yourself. Okay, so I have described to you previously that this scar is an indicator of a major adverse cardiac event. And I hope that all of you agree that the amount of the scar of the patient having burden is really significant. So this patient, he's going to have a sudden cardiac event. He's going to have VTAC. He is going to have a major adverse event. But that is one thing that we are going to talk about. But the successful vascularization based on the viability, I previously explained to you that the more the amount of the transmural scarring, the less successful the revascularization is. So if I measure the amount of the scar there, it's taking most of the myocardium, and just only a few segments that is viable here. So it is more than 75 to 90% scarring in the LAD. So if you have this LAD that is blocked, and you did this cardiac MRI for this patient, and you want to subject him to CABG, this patient is not going to have a benefit from the revascularization, because you have more than a third of the myocardium segment is having a transmural scar. The that has some reserved myocardium is the anteroceptive area, which is 3 or 4 segments, and the rest of these segments are transmurality. So your conclusion, you have to be confident about that. This patient will not benefit from revascularization because most of the LAD territory are having more than 75% scarring, and evidence gives you that this kind of patient will not benefit from revascularization. You don't agree? If you wanted to go back to the data here, that I just saw it to you, that the transmurality is the indicator for the successful revascularization. The more scarring you have, the more deep myocardium you have, the more failure you have for revascularization. Okay, so if you go back here to the data, I know that this is going to be, this is less than This is 50%, it's even less than our patient. 50% of those, this myocardium is dead or diseased, okay? And after revascularization, this is still thinned out myocardium. The patient did not benefit from the revascularization here, okay? So the transmurality was a very good predictor that this patient will not benefit from revascularization. Okay, so if it's more than 75%, this is deemed non-viable myocardium. Okay, 50 is considered to still viable. More than 75 to 100%, this is non-viable. Okay, so this patient, by definition, is not having a viable myocardial signal. That the most of the myocardia or the most LED territories now, actually, I don't know if you are in imaging. Actually, we divide the segments into receptor later, and then you count all those segments to see how many of them are non-viable. And if you go back to this patient, patients here, if I just give you an estimate, like a visual assessment here, in the late gadolinium, we have the basal segment, mid segment, the apical segment of the anterior wall is non-viable. We have also the receptor wall that has more than 50% scar. And then if you calculate this segments, you would see the majority goes for non-viable. So you would say that this is non-viable. Okay, there's any questions that you want to just say that you might disagree with me? Any questions? Yeah, more than 75% will not benefit from the revascularization. And be careful when we count the segments. We will count how many of those segments are viable. So if I have, for example, 13 segments, and I have example of 7 segments, that is non-viable. So the majority of those segments are non-viable, then this is likely not useful to have a successful revascularization. Okay, so just roughly understanding, the reporting in MRI has to be very, very detailed, and it has to be counting the segments and has the transmodality and the percentage itself, so you can have a very precise answer about revascularization. 50%, if you have 50%, then this patient might have a benefit. His chances to have a functional recovery is less than 40 to 50. It's about 40% recovery, but it is not transmural, but actually his benefit is 40%. So you cannot deny patients that kind of benefit. So you have to report that this patient is 50% scarring, and if there is still less than 50% of his LED is viable, then you kind of successful as a candidate for revascularization. As I said, his chance is not 50%, it's less than 40% for functional recovery, but you would deem him benefit. Any questions?
Thank you very much, Doctor, for this nice talk. I'm just asking about the ICD implantation based on the CMR scar tissue.
Yeah.
Do you do it even if the ejection fraction more than 30%?
Do you mean that we did MRI patients or we scan patients?
No. I mean, do you advise the patient to put an ICD if the scar tissue is more than 5%, even though the ejection fraction is more than 30? Do you implement this in your practice?
Okay, actually, the guidelines doesn't recommend such a thing for one reason only, not because it is not true, that because we have to have evidence. Actually, the study that is literature is not strong evidence that patient has been subjected to cardiac MRI for reasons that this is very expensive to be done about routine practice. So you might know new practice that not all patients have the opportunity to have cardiac. Most of the expertise is limited. The procedures worldwide is kind of expensive. So to have a robust data with large volume of patients, it's a very expensive trial. So we don't have evidence. We have small data. Those small data, it's not enough to put it as a guidelines. But for my practice, actually that's what we do. When we have LV dysfunction, and apart from revascularization, and I don't know what to do with the patient. Ischemic cardiomyopathy. I'm not sure. His ejection pressure is borderline. I will put him into cardiac MRI, see the amount of scarring, and if I have a high amount of scar, I will reassess him again. I would know for a fact that his ejection fraction is not going to be that stable, and at that point, I would refer him for ICT. The opposite is also true. Sometimes I have patients with low ejection fraction, and actually the patient doesn't want to have the ICT. And I don't have the confidence to tell him, well, you don't need the ICT because your ejection fraction is this, not every 5%. At this point, I would ask for cardiac. And if I find cardiac MRI has no scar, I would say, okay, I can wait for you. I can wait. And I think evidence gives me that when you don't have a cardiac, with only 4 ejection fraction, despite the guidelines, I can't wait. You get my point? This is how I use it to the opposite thing. Okay. Questions? Okay, so do you have enough breath to continue? Maybe because I have a quick talk about patient with non-ischemic cardiomyopathy that we use cardiac MRI for. If you want, I will continue. It's just part of quick knowledge that I want you to understand from that. Okay. Yes, here. Okay. So I'm going to talk to you about cardiac MRI and non-ischemic cardiomyopathy briefly as you look at it from my presentation. It is an indicator of predictive value. So I'm going to continue here. Non-ischemic cardiomyopathy, which is a dilated cardiomyopathy, one condition called ventricular non-contraction. The inflated cardiomyopathy, which is cardiac myocarditis, I'm going to hear about it so much because of the new drugs that is coming for the patients and cardiac sarcoidosis. And the role of MRI is I'm going to talk about it very quickly. If I talk about DCM, dilated cardiomyopathy, actually MRI is a very, very helpful way, as I said, to see whether this patient is really ischemic in the first place or not, and non-ischemic. And if it's non-ischemic, patient has only just dilated cardiomyopathy, cardiac MRI is a robust consistent ventricular fraction. In addition to assess also the amount of scarring, because those kind of dilated cardiomyopathy patients, they do have a dead space, they have myocardial fibrosis in their heart, and those has been proven to have an effect in the future event. And just guidelines about how you can differentiate between an ischemic scarring and non-ischemic scarring by the nature of the distribution of the scar and the location itself. So if I have like a transmural scar in the gadolinium enhancement, as is described earlier, if this scarring is consistent with coronary artery territories, like the patient we saw earlier, it was consistently flowing through all LED territories, then this is going to be a scar related to an ischemic insult. There are types of transmural scarring that can happen to the myocardium, but it's not really an ischemic scarring like sarcoidosis, amyloidosis. You can see sometimes myocarditis, but those kind of scarring is not going to be consistent with any coronary artery distribution. The other type of it is subendocardial, which is, as we saw also earlier, this is a scar that is also formed with the coronary artery distribution, and you have to be careful. Not all this can be enhancement is only for breast cancer. There are some patients with Chagas disease and coronary artery vasculitis. Sometimes you have an insult of the coronary arteries, and it is just simply because an inflammation, and it gives you the submucoid. And there are also the famous and most common global subendocardia, which is the amyloidosis, and is really very, very introduced disease. It gives you all sort of amount of scar distribution. And we have also the different types of the epicardial ganglion, which is mostly because of an insult of myocarditis, sarcoidosis, and I said also inflammatory Chagas disease. And here it comes to the more specific mid-war enhancement. This is, we see actually the fibrosis within the myocardium here, the white signal. It's going with the idiopathic dilated cardiomyopathy and hypertrophic cardiomyopathy. It's only those two pathologies we can see. And no gadolinium enhancement is actually an answer that can be happening for all patients with practicable pericardial cardiomyopathy, idiopathic dilated cardiomyopathy, sometimes also myocarditis if you send the patient to see it. So this is just a general view that you could have a differential diagnosis, and you could have a very good answer when you are sending patient to cardiac MRI to know what is the reason of this myocardial dysfunction by looking at the leg distribution. And I'm going to ask you, after you hear that, so if you have a patient with dilated cardiac, and do you think you do cardiac MRI, or you think I need cardiac MRI only because of the poor rate of ejection fraction? Or actually it's not indicated, or it has a prognostic predictors, or there is no clear role in the clinical practice, just an estimate. Hassan said 3 has a prognostic value. Anybody thinks that it is just a nice picture? When the patient is obese, it can have a very good ejection fraction assessment, or actually it's not very good. Or not true, it's not indicated. So maybe it's indicated, maybe it's not. Maybe it has a prognosis, or maybe it has no prognosis. We will see that. Here I want you to see the study data for patients to dilated cardiomyopathy, not ischemic. The prognostic value of late gadolinium enhancement has been done to those patients. Actually, those patients were selected to have moderate to severe induced ejection fraction. And as I said, we are all inheriting that if the ejection fraction is a prognostic value. Regardless of this part, this is all what the guidance has been stated. MRI data is not yet in the guidelines before, but this is an interesting study. They took a patient for cardiac MRI. Ejection fraction was less than 40%. They have excluded patients with diagnosis of ischemic cardiomyopathy. They took the patient with idiopathic cardiomyopathy, and actually they have done for the ejection fraction assessment, and they did follow up those patients with dilated cardiomyopathy. They assessed them if they have any kind of that. They had needed to have transplantation, that they have a hospitalization for heart failure. And we analyzed the left and right, and said that was the evaluation, the outcome they have assessed it for. So if you look at the primary outcome, all cause of death are transplantation, and the secondary outcome was this hospitalization because of heart failure, idiopathic cardiomyopathy. And they have found that the patient with late gadolinium enhancement that is positive. We found some mid-wall enhancement, fibrosis. They do follow up this patient. Actually, the amount of events that happen to those patients, the probability of those events is almost 50%. They might die and then go for heart transplantation. Or if you compare them to the patient with no late gadolinium, the percentage or the event probability was quite big patient. Also, the secondary outcome, which is a hospitalization patient with post-acute anemia, the probability is higher for them to have a myocardial event hospitalization. So it was a prognostic factor that has come out from this study, and actually it shows you that the presence of the scar is also an indicator of cardiac for the patient. And here's an example of the same study. Patient has a cardiac MRI. This is a clear and healthy cardiac test done. There is no uptake of the contrast. And here you can see a mid-wall bright segment coming into the septum. Here is another example, which is Hanfi cardiac. You can see bright segment over the lateral wall is the sub-AV cardiac segment, which is finding from the carditis. So, giving that data, so you have the myocarditis, the dilated cardiomyopathy, and you have done those kind of assessments to take a decision about the patient recovery. The ejection fraction by itself is not really an indicator to have the answers. And this is another study that has been also published about the amount of the scarring and all cause of mortalities for cardiomyopathy of the patient. And you see that the hazard ratio comparing to legacy enhancement, this is quite striking. So sudden cardiac increased and all cause of mortality increased. So in dilated cardiomyopathy, these are prospective data that can predict for importance to assess your patient outcome. I'm going to talk quickly also about hypertrophic cardiomyopathy. It is a inherited disease that is coming to have a thickness in the myocardium. Actually, hypertrophic cardiomyopathy is responsible and the most responsible cause of sudden cardiac death in young and also elderly patients. And we have a way to stratify this. Now, I'm sure that you're aware about stress stratification. So if you have a patient with hypertrophic cardiomyopathy and he has unexplained syncope and also family history of sudden cardiac death, and you default to a family that has an unsustained VT and he has a severe LVH, like more than 30 millimeters, and you exercise this patient in stress test and you find that no blood pressure is response. Those are the numbers to classify a patient to have a really indication of major personal cardiac event. And you might in future advise for an ICD. And this is the guidelines that stated the same. As I said, the more criteria you have, and the bad outcome. And like, as you said, there is no right data here, but lately the data came out in the last 2 years about the scar viability, the scar presence in hypertrophic cardiomyopathy, and I expect that it's going to change the data, future guidance to the implantation of ICD. And this is an example of a patient actually with hypertrophic cardiomyopathy. And and after we give a course in as I said, the data just came out and it needs more verification. This is another example also of a patient with ABK-HCM, and it was missed by echocardiogram because there is some limitation.
الدكتورة شكل الصوت قطع عندك. عفوا دكتورة. ما احنا سامعين.
Hello.
الو.
أيوة.
انقطع السلايدز والصوت كمان انقطع. ممكن تعمل شير سكرين مرة ثانية؟
I'm not talking about it because it's private medicine. No, that is not part of it, that is routine practice. I will go to another pathologist.
ما احنا شايفين السلايدز دكتورة.
At all.
Yeah. Can you share screen again?
Okay. So this is the screen, right? Can you see it?
Yes, we can see it now.
Very nice. So then the second pathology that we're going to talk about is the amyloid restrictions. And as you know, that amyloidosis has two types. It's the light chain, which is an ATTR. So this is a serious disease, and it is a very killing part of a systemic disease. So the involvement of cardiac amyloidosis is one of the major predictor of adverse cardiac outcomes. So you might expect patients, especially patients with myeloma, and having a treatment, feeling that this patient has a problem with the conduction or shortness of breath, it's a mandatory to do cardiac amyloidosis. And the debate is always between the or the cardiac amyloid, and I'm going to talk about the benefit of cardiac in amyloidosis. It is considered to be a diagnostic tool, and it is having a good sensitivity to predict the negative outcome, which is 60, about 88, respectively. So transthoracic echo, it can assess the ejection fraction. And cardiac MRI is more sensitive. Echo is 88%. MRI is 95%. Sensitive for myeloma. I'm pretty sure that you have seen patients who use transplant to use hypertrophy with bright signals, and this is a good sensitivity test, but also you could have a higher sensitivity doing a barbecue. So one of the things that we can add also is to give a new modality to assess the iodine, is the tissue mapping, which is without gadolinium. And it is a bit complex technique, but just giving you the notion of it, that is you can measure the value of the myocardium. Given this value, it gives you an indication that there is an abnormality or abnormal protein deposition. This is a case example for a patient that has been referred to us. And if you see that patient, I would say that from looking at this, this is the same as hypertrophic cardiac patient. This hypertrophied segment all over the wall. The ejection fraction, despite the fact that this is quite depressed, but actually after giving contrast here, this is a short axis view for the same patient. So yeah, you can appreciate the hypertrophy and also the reduced ejection fraction. So the whole segment will hypertrophy, and you might look at that and say, okay, maybe this is hypertrophic cardiac. If you move on with the contrast that we give to this patient, and actually you might think this is a poor image quality we're doing here. Actually, it's not a poor image quality. This is a very expected finding with the cases of myeloma that you lose actually the gadolinium kinetics. You have diffuse, like you can see here, bright signal diffuse subendocardial scarring here and there. This is here, there, and you think this is not a good quality, but actually that is a very typical for myeloma. So you have here this outer scar, and you have here is the septum in the RV wall, that is having a scar. And given this, it's not really a case of blockage. It is rather than having high so to some patient get assessment. And this is also an example of abnormal gadolinium kinetic. You cannot say that this is a bright signal as it's supposed to be in the early GAD. And this is a very, very unique features of amyloid protein interacting with the gadolinium. The last category that I want you to hear about is also a systemic disorders for sarcoidosis, and also there is a deposition problem, and it is a serious one. The cardiac sarcoidosis is involved, and it causes patient to have mortality of 65% despite patient has suppressive therapy. And actually, the Heart Rhythm Society suggested that whenever you have patients with cardiac sarcoidosis, ICD medication is recommended for those type of patients. And we have, as I said, in Brian Peters, to get this patient the right for diagnosis. Sometimes you are not so sure that this is an active disease, so you might ask for this. This is an example also of how cardiac sarcoidosis represents in gadolinium enhancement. And if you just refresh your memory, it was just like mild doses, kind of patterns, completely sporadic and not really clear. And in that case, sometimes you really want to have the diagnosis established whether this is mild doses or sarcoidosis. And actually, you need more data to guide through the diagnosis. That is my last slide to you. I hope that I cover most of your demands, and just give you a last notion about the ventricular compaction. Is one of the qualities that you see as a type of dilated cardiomyopathy. And when you see a lot of compaction, a lot of hypertrabeculation, the apical, the apex here, like this, I think this is a thrombus. This is hyper petrified apex. Is this actually the ulcerative myopathies, Chagas disease? You could refer the patient very nicely to cardiac MRI, and it will differentiate this kind of imaging that you see into this image picture, and you can see with confidence this is normal. This is a hypertrabecular rather than having hypertrophy or an inflated deposition in the apex. That is my last slide. I hope that I covered you to that. If you have any questions, please feel free.
الله يعطيك العافية دكتور جزاك الله خير. Floor are open for questions. لو في أحد عنده question he can write it in the chat or open his mic.
Okay, there's a question: is cardiac MRI detect active versus chronic sarcoidosis? That is very demanding question, actually. The only thing that can be decided whether this disease is active or not is the PET smear. MRI can give you the answer whether there is a disease or not, but actually for having the answer, it's active or not, actually we need a dynamic or an active metabolite to test that. This is going to be given by PET scan. PET scan, the active cells that is inflamed, whatever you name it, is going to pick up the tracers, and for this reason, you would understand that the it goes the same like affected myocarditis, whether you want to have this is a vegetative vegetation of this is actually advanced, just like other. So to assist the active metabolism is the tracer by PET scan is the way to. If not some other research, I think this is this question for you. I like the answer.
I will send the recording once I have it from the Saudi Commission.
Okay. Any other question?
يعطيك العافية دكتورة.
Thank you very much for your attention. Thank you.
نشوفكم على خير إن شاء الله. Thank you everyone for attending. السلام عليكم.